Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting on the WFMP 106.5 Forward Radio Community Network in Louisville, Kentucky, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare, in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe that healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system. Simply explained, it's Medicare for all, only enhanced to cover dental, vision, hearing, and prescriptions, starting at birth and covering everyone. Catch our program at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud so you can listen anytime. This radio station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Drs Michael Flynn and Shively join me as co-hosts, and our focus is on midwifery. So let's jump right in. Dr. Flynn?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer. Any comments I make represent my personal views, do not represent the views of the Department of Surgery or the University of Louisville. Gene?
I'm Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky. I've spent my whole career in rural surgery. I trained at the University of Louisville. My comments do not reflect the University of Louisville Department of Surgery or Taylor Regional Hospital in Campbellsville.
Well, we've got a special program today and with a special guest. The topic is the practice of obstetrics in Kentucky's current political environment. And our special guest is Brende Lott, who is a midwife in Campbellsville. And she has an impressive background. She got her Bachelor of Science Nursing in 2001 at the University of Kentucky, Master of Science in Nursing and Midwifery in 2012 from the University of Cincinnati, and a Doctor of Nursing Practice in 2022 from the Frontier Nursing University. Ms. Lott, Dr. Lott, thank you very much for your willingness to come on the program and talk with us about these important issues. As we have done with our guests in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then Jean will begin with the conversation. And I would ask you, while you're making these comments, most of our listeners are not medical people, and if you could maybe spend a little time explaining what you do as a midwife, I think it would help them understand the reason we have you on the program to talk about some of these issues. So, Brende, the floor is yours.
Okay. As a certified nurse midwife, my role is to take care of women really throughout their lifespan, but primarily women during their reproductive years. So I do in-office gynecology, routine annual exams for adolescents all the way through elderly patients, provide counseling on contraception, insert and remove long-acting reversible contraceptives like IUDs and Nexplanons, and then provide care in the office for prenatal visits. And then I do attend and manage labor and delivery at our local hospital, and then see these women in the hospital and in the office for postpartum care.
Okay, thank you very much. Jean, do you want to start the ball rolling?
Yes, I'm so glad that you are here and talking to us. we ran into each other at the Taylor County Hospital Health Fair and got to talking. And I asked her if she'd be on the program because most people really don't know what a midwife does. And we're actually neighbors. She just lives about 4 houses up the street on Lebanon Avenue. I'd like to ask you, what kind of education do you have to be a midwife? Do you have to be a nurse practitioner? Tell us a little bit about what that entails and the various ways you can be a midwife.
Yeah, I'm so glad that you asked this question. I think this is probably the most confusing thing. And there's a reason it's confusing for people because there are many different kinds of midwives and a few different paths that a person can take to become a midwife. So there are lay midwives or a direct entry midwife, and that might be somebody that you see like in an indigenous community or some of our Amish communities where we just have somebody that kind of becomes their role. They've attended their family members' births, and then they become the person that the community goes to. I have a 5 times great grandmother whose death certificate says she was a midwife. Well, she probably just learned that in her community, right? Then there are some midwives that are apprentice trained, and they can take a certification exam, and that certification makes them a certified professional midwife. And then there's the type that I'm most familiar with, which is the type that I am, and that is a certified nurse midwife. So to be a certified nurse midwife, we have first a bachelor's degree in nursing, and then those nurses go on to study midwifery, and that's either through a master's degree or a doctoral degree. And this would be the most standardized form of education in midwifery. We meet at kind of national standards for a baseline in education and then take a national board exam to be certified. We're legal in all 50 states. Certified nurse midwives can bill Medicaid and can bill private insurance for our services. You don't have to be a nurse practitioner to be a certified nurse midwife. However, in Kentucky, all advanced practice nurses fall under that same umbrella of advanced practice registered nurse. So through our board of nursing, all neonatal nurse practitioners, family nurse practitioners, geriatric nurse practitioners, CRNAs, nurse midwives were all, licensed through the state under that APRN title, if that makes sense.
Okay, Brende, can you tell us and share with our listeners the difference between what you do as a midwife and a doula?
Yeah.
I'm not very clear about that myself.
Yeah. And there are a lot of people that aren't clear on that. So a doula is somebody without any medical training at all. So they are somebody that is trained to help support a mother in pregnancy and their spouse or partner too, which I do think that's really important. And they're there to help educate them on what some of their options are during labor and birth, to help prepare them through some childbirth education classes, perhaps, to be a support person during labor. And then there are some doulas that do postpartum support that come over and help prepare a meal or do laundry or maybe help that mom do a sitz bath, that kind of thing. Whereas a certified nurse midwife like myself is somebody that had 7+ years of education to do the job that I'm doing. Medical education, essentially. Yeah.
Now you have your doctorate degree from a Frontier Nursing Service, correct?
That's right.
Now, it's my understanding that Frontier Nursing Service, which has been in Kentucky for many, many years, trains a majority of the midwives in the United States. Is that correct?
They do, and it's a really proud tradition and a very cool thing, I think, for Kentucky, that we can lay claim to that service. So that Frontier Nursing Service was started by Mary Breckenridge in the 1920s, originally in Hayden, Kentucky, after she attended midwifery training in Great Britain. where the majority of births are attended by midwives, and still are. That Frontier Nursing Service or Frontier Nursing University is now in Versailles, but they do train about 25% of the country's midwives.
And it's in Versailles now. It's not in Appalachia?
That's right. They relocated to Versailles, and they did that for convenience mostly. So when we're getting students that are coming in from out of state or across the country, they're able to fly into Lexington, and that trip to the university is not quite as cumbersome as it used to be. There's a little bit of sadness there in that history, not being located in Appalachia anymore, but still in Kentucky.
Now, you just do vaginal deliveries, correct?
Yes, sir. Yes, sir. That is a hallmark difference between midwives and OBGYNs. So I'm not going to do anything that is surgical. So that involves C-sections, cerclages, a dilation and curettage. If we have anybody that needs those kind of things, that's going to be done by a surgeon. A 3rd or 4th degree perineal laceration. So if let's say I've attended a vaginal delivery and I have somebody who's had a very large laceration, a 3rd or a 4th degree tear is a surgical repair. So an OBGYN is going to be called in to perform that repair. Although I will say that in my career of 25 years, I've only had that happen once or twice. The vast majority of my patients do not have any lacerations or tears at all. And then those few that do, around 7 or 8% of my patients are going to have a 1st or 2nd degree laceration. And I think that kind of comes down to some of the differences in the way that we attend our birth and what we do. And midwives are really trained not to intervene unless there's a reason to intervene. And we're there to recognize if there is a complication and to respond, but we're not routinely cutting episiotomies, and we're really there to support and not to intervene.
Do you have a backup system when you do these deliveries? Somebody who's standing by if you need help, or how does if you could explain maybe to us and our listeners how that works?
Yeah. So I'm practicing here in Campbellsville, which is a much more rural location than where I've spent the majority of my career. I've worked the first decade at the University of Kentucky, and then I spent about 15 years in Owensboro, which is my hometown. And so in Owensboro, and this is how they still operate, there's going to be an OBGYN hospitalist that's in-house 24 hours a day. And that's a really nice luxury. We don't have that here. And so practicing in a more rural setting, I do have a backup physician that is on call at home. And so they have a 30-minute call time, and that does influence the way we practice for sure. So we really need to anticipate when we think there might be a need to have that backup. We're in really good communication with our backup physician. If we think that we have somebody that might need a C-section, you're not waiting until it's an emergency, right? We're discussing and contacting them earlier on than we would need to if we have somebody who's just down the hallway. So I do have a backup OBGYN physician, and that call kind of rotates, but they're going to be usually at their home.
I remember the day when episiotomy was routine in deliveries. And I guess I'm aging myself, but that was just a routine procedure.
Right. And so, what we've kind of followed the evidence, right? And what we've learned over time is that women that had an episiotomy were much more likely to have a tear that extended beyond that episiotomy. And so that has, I started working at UK in 1998, and I really believe at that time it was already kind of out of fashion. It was not routine anymore, and which is wonderful. Now we have women that have much more intact pelvic floor, a lot more structure to that pelvic floor. that's something we work really hard on. We really want women to not just get through their labor and their birth, but for their long-term health to be optimal. As a woman in my mid 40s now, I really look at these women and think, okay, I want you to get to middle age and still have really good control of your bowel and bladder. It's really important.
Now, do you do any anesthesia, or do you leave all that up to the nurse anesthetist or the anesthesiologist?
Well, first, I'll say that women that are under the care of a certified nurse midwife can absolutely have anesthesia, and that's sometimes an area where people are confused and they think that if they're seeing a midwife, they have to have a completely unmedicated birth, and that's not the case. Now, as far as the person who administers the anesthesia is going to be the CRNA. Nurse midwives are not performing epidurals, anything like that. Now, our patients, if they don't have an epidural, can absolutely have IV pain medicine, and the registered nurse is going to administer that. In some facilities, nitrous oxide is used for analgesia or pain relief during labor. If we have somebody that might need some local, like some lidocaine, if we're doing some suturing afterward, we would be the ones to administer that.
Where do you do the birth? Was this done in a birthing center, or is it done in a hospital area, or in the home?
Yeah, great question. So most certified nurse midwives in the United States are attending births in a hospital, the vast majority. There are definitely nurse midwives, and then some of those other kinds of midwives are doing births at home. And currently in Kentucky, there are not any birth centers. So every birth that I attend is in a hospital.
Now, I know that there's a lot of controversy in the legislature recently about birthing centers. What's your opinion about that? And do we need to have birthing centers?
Yeah, that's a great question. And it's something that's been in debate for decades. So actually in March, House Bill 90 was passed, and that was an act relating to birth centers. And it eliminated the requirement that there be something called a certificate of need. And that was a requirement that if somebody wanted to open a birth center, they had to prove that there was a need for that. And you can imagine that hospitals and hospital administrations fought very hard against these birth centers because that's competition. Essentially, that kind of comes down to the financial aspect of that. The bill in March, our legislatures actually tacked on a lot of abortion wording into that law, and our governor vetoed the bill because of that additional wording related to abortion services and access. But his veto was overruled, and so this has passed. And there will be, at some point in the future, birth centers will come to Kentucky. Personally, I think that it might be a bridge for us. And we have a lot of areas where there are maternity care deserts, lots and lots of counties in Kentucky without any access to an OB provider. And maybe they don't have a hospital at all, or their hospital doesn't do any obstetric care. So I'm hopeful that perhaps, birth centers that are well regulated and have really good mechanisms for safety and backup and that sort of thing might be a way for us to provide better care to certainly more of our rural populations.
Okay, well that brings up a question that we need to discuss, and that is, I just read an article just this morning from the AMA where there's been, in the last 10 years, a dramatic decrease in the number of hospitals who are doing OB. And can you tell what's happening in the state of Kentucky, and what you think what's your opinion of that? And also, I'd like for you to discuss the effect of decreasing Medicaid in the state of Kentucky and what that will do to OB services.
Yeah, and so the current situation and the future, both are pretty bleak. Over the last few decades, reimbursement for obstetric services has decreased significantly, number one. So we know that most facilities, especially our small rural facilities, are going to lose money when they're providing OB care. And that is because we need to have a minimum staffing in order to provide safe care. So whether we have 0 patients or 2 or 3 or 4, we have to have the same minimum number of nurses available. And I can say that we know that our facility here loses money most years on obstetric services. So it has to really be a dedication from the community and from all stakeholders to keep those units open, because it's incredibly important for our community to have safe access to OB care, whether we're making money or not. Now, as far as cuts to Medicaid, it's really terrifying. It's terrifying when we already have hospitals that have had to eliminate their OB service because they couldn't keep the doors open or pay the bills or pay for their staff. We know that's going to significantly impact the majority of the birthing hospitals in Kentucky. Basically, every hospital that's not a large university system is in danger. And that includes the facility where I work, and maybe not necessarily Owensboro, but all of the other regional hospitals in Western Kentucky are in danger. And that is very scary.
Can you break down the reimbursement issues in your practice, or in a general a midwife practice, like percentage of patients that have got private insurance? I assume you don't have very many people with Medicare.
Yeah.
And what percentage are on Medicaid?
Yeah, I don't have those numbers specifically, and of course it does vary region to region. My friend who works with me, who came down from Lexington and was in a private practice there, saw the majority of private patients at that particular practice. The practice that we're in here, you're right, we may have a handful of patients with Medicare, not very many, and the vast majority of our patients are Medicaid patients, and then we'll have maybe 20% or less are going to have commercial insurance. And so when we look at the way that we're reimbursed there, for somebody with commercial insurance, we get one global fee for all of their prenatal care, for their labor management, for their delivery, and their postpartum care. So that's going to be somewhere in the ballpark of $2,500 to $3,000 for everything. So we really have committed to caring for somebody for 40 weeks, potentially have done a whole lot of work. We get one lump sum for that. With Medicaid, we're going to see about $20 back for Medicaid per prenatal visit, and then about $500 for that delivery. And again, whether it's incredibly complicated or not, that's their rate that we're going to get back for that. And we get about $25 or $30 for a postpartum visit. It's not very much money. And when you look at the amount of, especially in this population that are sick, that may not have good access to food. And we do see a lot of food and travel insecurity in this area. And we really do put a lot of heart and soul in trying to provide good, safe care to these moms. And we don't get a lot of money back for that amount of work.
So what do you see is going to happen when the big, beautiful bill, which is also a big, beautiful piece of crap, in my opinion, goes into effect after the 2026 midterms? Assuming that doesn't change, what are you looking at over the horizon?
I think we're going to see a lot of things that are really frightening in obstetrics. So we're going to see some women that aren't going to have access to Medicaid at all. Maybe women right now that are working in low-income jobs and are able to get Medicaid because of their income status, might lose their Medicaid if they have to be off of work for example, during a pregnancy, and they may not qualify for any benefits with the job that they have. These are the kind of patients that just stop coming in for care, and they're going to show up when they're in labor. Well, that's much more complicated when you don't have prenatal care. So we might have somebody, especially in this region, with significant anemia. I've never seen anything like it in my life. And women that come in with a hemoglobin of 8 or 9 prior to delivery. And for any listener that's not medical, that's very low. And so then when we have a normal blood loss with delivery, these women have significant anemia, where we're worried about their kidney function. Or do they have enough blood volume to sustain life? And we're transfusing a lot of people here. So I worry about that we're going to see women that are just coming in sicker. But that's on the patient side. When we look at the institution, are they even going to have an OB unit to come to? So if we have a unit that's already losing money and barely keeping the doors open, 2 or 3 years from now, will that unit just be closed? And then are we going to have providers available? Are these facilities able to recruit and retain people to work on these units if we're not being reimbursed in the same way, or we have fewer patients that have Medicaid, those people that are coming in without any insurance at all? And it's just really easy for me to see somebody like myself being forced to leave the area and go to a bigger city where I know that I'm going to have that job security. And that leaves these rural areas kind of in a dire situation.
Now, this may not be a fair question, and if you don't want to answer it, it's okay. But, it's my understanding that Campbellsville is a Trump-supporting area. Do the people that live there that you encounter understand or recognize what the future holds with the some of these the big beautiful bill, assuming that they don't change anything between now and then?
Yeah. I did move to a very red county, which has been a difficult adjustment for myself and my family, for sure. I don't think that the patients fully understand. Most of them don't. There's something very interesting about Kentucky as a whole. I think a lot of people don't see themselves in, when we're talking about Medicaid, in particular, I don't really know why they don't see how that affects them, or maybe they see WellCare is the name on their card and they don't think that there's somebody on Medicaid. I don't know why that happens. I do have a handful of patients that seem to understand. And so I will say that Campbellsville is actually a pretty educated community. We have a university here, and I see a number of patients that work for the university, and they seem to get it and understand and recognize that we're in danger here. But the vast majority of our patients don't. They don't understand that they've perhaps voted against their own interests.
Yeah, Gene, you want to answer that question as well? You've been down there for a long time, and I think you understand whatever is going on through the heads of most people that live down there.
Well, I don't think they understand the consequences of what might happen. It's like having cancer. You don't appreciate it until you get it, or unless you've taken care of a patient like cancer. People don't appreciate head and neck cancer until you've seen the consequences of it. And I think the real issue is they don't realize what could happen. It's not only a medical problem, but it's an economic problem. I think the hospital here it's the second largest employer in the county. It's either second or third, and that will have a severe economic problem. But as you just think about the consequences of this, right now, if we lost our OB And somebody who doesn't have any insurance doesn't go get prenatal care, and then shows up in our emergency room in labor. Just think about it. Most doctors today is different than when you and I went to medical school. We were trained in OB. I did OB as a student, an intern, and even in the Air Force. And then when I started in practice, I occasionally had to do emergency C-section. But most doctors have no experience in that. So what are you going to do with somebody who were to come into our emergency room in labor, and there are no real doctors who had experience in OB, and the closest hospital maybe E-Town, which is 45 minutes away, who would provide that service? I would assume under the reduction of Medicaid that all the hospitals around here would stop delivering babies, including the Springview Hospital over in Lebanon. The Springview Hospital in Lebanon is on the list of 35 hospitals that could close in Kentucky. So we would dramatically increase the competition of delivery, and I think maternal mortality and infant mortality if we do that. And it's really quite scary.
Well, isn't that what they call a maternity desert?
Mm-hmm.
Yeah.
Yes, yes. And so when if you kind of picture the geography of Kentucky, and we look at where Campbellsville is we're the geographic center of the state, just south of us in Adair County, there's nobody that is delivering babies, right? And so then you go south of them a little bit to the east, there's Russell County, there's nobody there delivering. And so let's say we have and I see a lot of patients from Russell County. If they have traveled over an hour north to get to us, and our facility's no longer delivering babies, and then they have to be transferred on either to Elizabethtown or Lexington or Louisville, we have delayed care by hours and hours. And that is frightening, because a woman can bleed to death in minutes.
Well,
so it's really a scary proposition.
Yeah, and I've said this before on this program. I'm going to say it one more time, and Jean knows pretty much what I'm going to say. There was a retired surgeon from Louisville about 25 years ago, a general surgeon who ran for public office, and he was elected to the House of Representatives, and gave a talk at the Louisville Surgical Society. And he made two very strong points. Number one is something we've all heard before, that making laws is like making sausage. And the other thing he said, and he was very serious about this, is that the politicians do not understand health care. And you can see that in the legislation that has been passed recently by the legislature, the national legislature, as some of the consequences that we were just talking about, and the Kentucky legislature as well. Everything from the gun laws to the anti-abortion laws, and some of the economic consequences of what we just talked about. One more quick issue, and I'm going to let Jean go on to the next question. Is my understanding that most rural hospitals are one of the major employers in that area. Now, do you both recognize that? Is that a true statement, or is this just something I picked up?
I think that's absolutely true. I think that's something that our governor has mentioned multiple times, that in most communities, the school system is the number one employer and the local hospital is the number two employer. And I think that that's absolutely true. In Western Kentucky, where I'm from, if you look at all those counties surrounding my home county of Davis County, and even in Davis County, that's the truth. And I think that that's accurate here as well.
I agree. In Campbellsville, I think Amazon is the number one employer, and then it's either the hospital or the university, and then the school systems. I would bring up another issue. We've had several discussions about people going in OBGYN and doing their residencies, and the data shows that medical students are going out of state to do residencies in OBGYN and not coming back, and that there are people who finish OBGYN residencies in the state of Kentucky go to other states because of the abortion law, not particularly because they're opposed to abortion, but because of the complication of pregnancy. And they have somebody comes in with a complication, their hands are tied, and they feel very frustrated and they can't take care of the patient, and they also puts them at risk for liability. Do you think this is a true statement? And is it also affecting midwives as they consider Kentucky for a place to practice?
Yeah, I do think it's a true statement. Abortion care is medical care. So it absolutely has affected my practice, and that the Dobbs decision has made obstetrics less safe for many parts of the country. We've had specifically women in this area that we have had to direct to Cincinnati to get necessary care. And that's not something that everybody can afford to do financially, or time away from their job, or we don't have everybody with a reliable vehicle. There are a lot of obstacles to care, and so it's very very disheartening emotionally. That takes a toll on us for sure. But yeah, I do think that it's something that's very real, and I'll share a personal story with you guys. My own daughter is expecting a baby in November, and so we're thrilled with, excited, looking forward to our first grandchild. My daughter lives in Murray, Kentucky, and she had first trimester testing that came back abnormal and came back a high risk for monosomy X, which was really terrifying and scary. And I reached out to some friends in Lexington and Louisville and Owensboro, maternal fetal medicine doctors that I know well, and said, where can we go to get a chorionic villus sampling? And I knew what kind of testing my daughter needed to confirm just the screening. Was the screening accurate? And there was nobody in Kentucky that could perform that service for her. And we were able to get her in with the doctor in Nashville quickly, and with the recommendation of one of my friends. And thank God that was a false positive result, and she has a healthy baby expected in November. And I obviously there are no words to say the relief that we've had, but I will just say that I'm very much aware that my daughter was able to go to Nashville and have this testing done because I could afford to get her where she needed to go. And I would have also been able to get her access to whatever other kind of care she needed, depending on what those results were. And that's not right. It's not right that not all women have that access to care. Now, as far as midwives in the state, I don't know that we're seeing midwives or midwifery students leave the state to get further training. I know that there are definitely students that have to seek out their own opportunities to learn. And maybe that means going out of state for a time. That's a little bit different than, our residents, when they're in a program, they're in that program, whereas midwife students really can travel out of state and go do a rotation in Arizona or, whatever. So I don't know if that's something that's happening or not, but if I had a student right now, I would encourage her to seek learning opportunities outside of Kentucky.
Now, the residents in obstetrics and gynecology in Kentucky have to go out of state somewhere in order to have the abortion training that they need to meet the standards of the American College of Obstetrics and Gynecology and take their board exams. So, and this, this is another example of what that surgeon told us 25 years ago about politicians. They've written laws that are confusing, they're vague, and create a situation where it's actually against the law to do the appropriate medical practice for some women with the complications of pregnancy.
Mhm.
Now, go ahead, Gene.
Um, how do you, can you tell us a little bit? Obviously, we don't want to get on individual patients, but what type of patients that you see in your practice that come in and you have to transfer out of state, like to Cincinnati, for care?
Yeah. So, yeah, and we do have to be careful because this is such a small community. Even sharing an example without a name, we don't want to violate anybody's privacy. Being in a small place, people can be identified, but I have seen a second trimester rupture of membranes. So somebody whose water broke around 14 weeks. For listeners that are not medical, the earliest that we're able to keep a baby alive outside of the uterus right now is at the earliest around 22 weeks, but forever 24 weeks was kind of our age of viability, but we've kind of eked that back a little bit over time. But 14 weeks is long from the time where we could keep a baby alive. And that amniotic fluid is incredibly important for the development of those lungs in the baby. And so when we see water broken that early, we know, number one, that baby can't survive outside of the uterus, and we don't have equipment or the ability to keep that baby alive. Number two, we know that that mother is at an increased risk of infection, and that it is an infection that could make her septic or die. That could lead to that outcome. But number three, even if we had a mother that did not become infected and a pregnancy that continued on, we have a baby that is very unlikely to ever have lung tissue and be able to breathe on its own, even with our support. So that is a situation in which a woman prior to Dobbs would have been offered what we call a therapeutic induction of labor. And so when I worked at UK, we would have had those moms come over to the labor and delivery unit, and an induction of labor would have been started, and we would have very compassionately cared for that family, knowing that this was not a decision that they made. It wasn't a choice that they made. This is just something that happened, and we want to take great care of that mom and preserve her life and her fertility, right? And so if we have somebody that's in a situation like that now, and the baby is still alive and she is not septic or at death's door, we cannot induce her labor. We cannot offer her that delivery anywhere in the state of Kentucky. And so the way this wording in the law is, it's so vague that people will argue and say, well, if her life is at risk, you can do what you need to do. Well, who decides when her life is at risk? Who gets to make that decision? Is it when she's bleeding to death? Is it when she goes to the ICU? Is it when she's already septic? When does that patient become sick enough that we can provide the right kind of care? And because that area is so gray, and we all are fearful for our own ability to work, we want to take great care of people, but also my life is, and my profession is on the line too. And so these are the kinds of patients that we say, if we're able, we want to get you to a place where you can have the care you need right now. And maybe that's Chicago or Cincinnati. It's not going to be in Kentucky or Tennessee or anywhere in the South.
It's too bad that information can't penetrate the brains of the ideologic Neanderthals in the Kentucky legislature that are passing the laws. Do you have medical liability insurance?
Yes.
Is that a really expensive issue? Is it not so expensive? Or, are there different levels of it? Could you just explain that to us?
Yeah, that it is very expensive, and that is part of the cost of providing OB care to these facilities. So that is something that is paid for me by my employer. And that's going to be one of those costs that facilities that offer obstetrics have to have, because lawsuits in OB are so incredibly expensive that liability became a reason why a lot of people don't go into OB. But it is important that we keep that insurance, and I do have that, thankfully. And then that is something that will be carried on, is that we have something called a tail that goes on for years and years after we leave that practice, because people are able to sue us for up to 18 years after their birth.
Now, I want to bring up another issue. What if you have a baby that is not viable after delivery? There are a lot of genetic abnormalities, but just to give one example, anencephalic baby, and for our non-medical people, that means a baby with no head. That actually exists, and that baby can live in utero till it's delivered. How, under the current law, how do you deal with those type of issues? And explain to me what you have to do, and also explain to me, is it possible that we could still have an anti-abortion law and adjust the laws so that they could be written that we can take care of women with complications of pregnancy and take care of non-viable fetuses?
Yeah, so prior to Dobbs, when there was a diagnosis of an anomaly that was not compatible with life, again, those are women that might have been offered an induction of labor. That would have been one of their choices. So that was something I saw in the beginning of my career. And if we had a baby that was anencephalic, or a baby with no kidneys, a condition where we know the baby will not be able to live on the outside of the uterus, no matter what our support is, no matter what level of NICU you have. Those are babies that won't live. Those parents were offered delivery, and then they're able to grieve that baby and then hopefully begin to move on. After Dobbs, that was something that is not allowed. So these women are forced to carry those babies until they go into labor or they can be delivered at term, which is incredibly cruel for that mother and her spouse and their other children. Everybody, they have to watch this pregnancy progress. And then we also are putting these mothers at pregnancy risks. There are potential complications with every pregnancy, and pregnancy is not a risk-free condition. So the further that pregnancy goes, the more risk there is to that mother. As far as whether or not there can be a law that allows us to care for those women, I think we used to have it. We used to have that in Kentucky before these trigger laws went into place. There were not, women could not go and get elective terminations after a certain point. We had one clinic in Louisville for years and years where women could have an elective termination. But we were able to care for women that needed our care in the hospital. Somebody that had an ectopic or had a missed abortion or missed miscarriage or an incomplete miscarriage, we were able to do what we needed to do to provide the care that mother needed to live. And now all of that falls into this gray area. And then certainly when we had babies with anomalies that were not consistent with life, those parents were offered every choice. And every choice was more than right now, which is your only choice is you have to carry that baby to term or go out of state. Again, there are still places where those women can go if they have the means to do so. They can travel out of state and be delivered far from their home, far from their family, far from their doctor, far from the people they know.
Now, what are you doing now with incomplete miscarriages and tubal pregnancy?
Yeah, so those are those are going to be a great question for an OBGYN. Those are situations that so anybody with an ectopic or suspected ectopic or tubal pregnancy, I'm immediately consulting the OBGYN physician to come and manage. That's not something that a midwife is managing, whether that is surgical management or medical management, like with methotrexate. They're going to come and manage that. And now miscarriages, midwives manage often. And so if there's not a fetal heartbeat, then there's not a gray area. Then we can offer medication management. So we can give Cytotec, those medicines that are still legal. We are able to prescribe those to help facilitate the completion of that miscarriage. If there is still a fetal heartbeat present, then my hands are tied. And that is where we fall into that gray area. And it would be called people think of that as an abortion, whether it's elective or not. And that is where we're going to have to wait until the bleeding becomes worrisome enough or severe enough that mother's life is in danger.
Now
let me ask a question now. If you've got an incomplete miscarriage and the patient is significantly bleeding, and you're having to give the patient blood, can you go ahead and go ahead and try to do a DNC in order to take care of the problem, or is that still a gray area with the current law?
If there's a fetal heartbeat, even if that mother, so let's say there is a fetal heartbeat there, even if it's abnormal, even if we all know this miscarriage is inevitable, if there's a fetal heartbeat there, then we're going to be speaking with a hospital attorney. We're going to have to involve them in the care and decision making of that patient.
Okay, just one more quick thing here. We are getting toward the end of the lollipop here. We've got about 4 minutes, a little less than 4 minutes left. So we need to think about finishing up. Jean, you want to have another question? Then, Brende, we're going to let you have an option to make a few final comments. And then Jean is going to, Paul is going to take us out.
So essentially you're telling me that a patient with incomplete miscarriage who's having significant bleeding, we're going to have the hospital attorney make the decision to treat the patient or not. I really
welcome to Kentucky in the 21st century.
Yes, that's it. Yeah, we all know that that's completely absurd. And that is not the kind of care that we want for our daughter, our sister, our mother, any of our own loved ones. That is not the care that they deserve and not the care that they should be getting. But that is the care in Kentucky in the 21st century.
Brende, you want to make a few comments before we finish up? I want to thank you for coming on. This is an excellent program. I would like to be able to take this and send it to the Kentucky legislature and make every legislative member listen to the comments that were made here. So thank you again, and the floor is yours to make some final comments, and then Paul's going to finish us up.
Well, I appreciate you all having me on, and it is great to be able to have an opportunity to talk about midwifery in Kentucky and what midwives do, and maybe to clear up some confusion about the education and background and services that midwives provide. I really do feel like access to midwifery care really may be a great solution for the maternity deserts that we have. And if we had a midwife or two in every county, I think that we would see a significant improvement in our maternal and infant outcomes. And as far as our legal situation in Kentucky right now with our ability to care for our OB patients, I'm just hopeful, and I think it's important for all of us to continue to advocate for change.
Thank you again, Paul.
Brende, I have a question. After the Dobbs decision, was anyone like you called in to give any testimony concerning the ramifications of the trigger laws that were going to be activated in the state?
Ooh, that's a great question. Not that I'm aware of, nobody that I know. And obstetrics in Kentucky is actually pretty small. And my, decade at UK, helped me. I got to know all the residents and the medical students that we trained during that time, and they're all over the state now. And so I feel like our network is actually pretty small, and I don't know anybody personally that was asked about. So Dobbs, of course, was the national decision in the Supreme Court, but these trigger laws and things that went into effect at the state level, I don't know anybody that was involved in that.
It sounds criminal to me, actually.
Yes, sir. Mm-hmm.
It is.
Yes.
It requires that when an obstetrician or a midwife is dealing with the complications of pregnancy, they are basically forced by law to conduct medical malpractice.
Yes.
It's terrible.
Yes. Agree.
Yeah. I want to congratulate you again for decreasing the C-section rate at our hospital. I think that's a dramatic change, and you should really be congratulated for doing that. That's just wonderful.
Thank you. We're really hopeful that we continue to make good strides here and that we're not taking back 50 years with changes that are coming down the line. Yeah.
Well, thanks again. Goodbye.
Yeah, thank you all. Bye.
Bye-bye. You've been listening to Single Payer Radio. Thank you for tuning in, and I hope you tune in again.